today. We were worried that there's everybody's super busy with the COVID, that they might not join. So we really appreciate you guys joining us. Just gonna maybe just give a couple minutes for people to sign in. Sometimes it takes a moment to register. Okay, great. Thank you. Okay, how's everybody doing? Everybody okay? Hanging in there? I'm waiting for the month to be over already. It's supposed to peak, right? And then go down. So I want to skip that part and just go right to the end part.
Yeah, I think so. There's just so much happening at the moment. So
yeah, so hang
Yeah.
tight, everyone. All right. So anyway, I guess I'll just go ahead and do some of the intro slides. Today we're, oh, you're doing great, Janelle. Kamahele. Janelle, I haven't met you. Where are you from?
Aloha, I'm from the Big Island,
Oh, wonderful.
and I used to do nursing. And right now I am just currently trying to keep up.
Uh-huh. Yeah, I think we're all trying to keep up.
Hi,
Great. Who else don't I know? I know Coral, I know Noreen. Hi, Noreen. Glad to see you.
Hi, Aida.
Yeah, I don't know Coraline. Hi, Coraline.
Hello, I'm a social worker up at Kula Hospital on Maui.
Oh, wonderful, wonderful. Okay, so good. We'll get some experience sharing from other places as well. That's great. Okay. All right, so anyway, here we are. This is our series made possible by GWEP funding through the University of Hawaii and our sponsors, and partners from HAH, Mountain Pacific Quality Health, United Healthcare, and Aloha Care. Next slide. And of course, we want everything to be confidential and safe. This is a safe learning environment where we encourage each other and share. These are cases, we are free to basically discuss cases, but make sure they are HIPAA compliant. We run our ECHO Learning Action Network on the second Tuesday of each month from 2 to 3 p.m. And today, our session is putting behavioral activation strategies into practice. So yeah, I'm excited to hear from social workers who put that into practice. Maybe you guys have more ideas for us as well. And these are the learning objectives for the whole series, really, which is really trying to help each other, support each other for well-being, for pandemic and recovery phases, practice age-friendly health system strategies. And this series is on depression and loneliness. And then talk a little bit about QI strategies and working with quality measures and increasing our knowledge of regulatory guidance for COVID and quality measures and staying up to date and keeping up with all the changes that happen, that change every day, minute, hour. Yeah, next slide. And this is just for CMEs. Make sure if you got on, you registered, and all you have to do to get CMEs is to complete the evaluation. So after the session, the link will go into the chat box and you just click on that and just do that right away. Okay, and this is our hub team. That's me. I'm the course director. I'm today's speaker. Dana Mitchell, our QI coach, should be. Is she here? Yes, she's here. Hi, Dana. Want to wave hi?
Hi, I'm here. Oh,
yay. Okay. And we have Lori Henning, our faithful HAH rep, Great. And Gail is out, so she'll join us when she can. So yeah, just wanted to open this up. How were the holidays for you? Did you do anything for yourself? Hopefully, this has been a rough year. Anybody? Just going to open it up and see if you use this time to regenerate, renew yourself. Feel free to use the chat box. Hang out with family, anybody? Spend some good time. Nobody did anything for themselves. I know you guys did. Ate lots of food. Yes. Spent time with local family. Yes. That's great. Yeah. Or actually just slept. Tried to rest a little bit. I actually took a few days off in between. All right. Well, hopefully after today's session, you'll have even more ideas of how you can take care of yourself. Some more. We're going to review that. And here's another question. How are the holidays for your residents? Did you guys do anything special? And did anybody do anything that went particularly well for the residents? It's really been rough, I think, for the residents as well. You guys try anything that was different? No, Renelle was answering the last question. Not much time to spend on self-care. That's true. So that's why sometimes we have to think about how do we do something that takes care of others and ourselves at the same time, because you can't do just one thing.
So Renelle is at Kula Hospital too, but at Kula Hospital, we had one of the residents dress up like Santa Claus, and like he went around and like we do this every year actually, but well, not every year, but every year since COVID. Usually we have a Santa Claus come in from outside, but the last 2 years we had a resident just go around, but obviously social distanced and whatnot. But I still think that it's just so hard because it's not the same as it used to be for the residents. So as much as we do, it still just feels like any other day for them. So it's a little sad.
It is kind of sad. But that is nice. I'm glad that he took the effort to dress up as Santa Claus and try to bring some cheer. I'm glad that you tried. Okay, so Lori, you want to go ahead and pull up your slides and we can talk a little bit about some COVID updates.
Okay, give me just a second. So I can pull up my slides here. Okay, do you see those?
Mm-hmm.
Fantastic. Okay, aloha everyone, and thank you for joining us today. So COVID-19, there's a lot going on. So I just wanted to start with the latest information. So this is regarding the at-home COVID-19 tests for individuals. So yesterday, CMS announced that the Biden-Harris administration is increasing access to COVID-19 tests for the public. Beginning on January 15th, the insurance companies and group health plans will be required to cover the cost of over-the-counter at-home COVID-19 tests. So this is just some information for you personally and your staff. So individuals with private healthcare insurance coverage, or if you're covered by a group health plan, will be able to get 8 free over-the-counter at-home tests per month. Now, this is different from the tests that are ordered or administered by a healthcare provider. There are no limits to the number of those tests because they're the result of an assessment that's been done by a healthcare provider and it's been clinically indicated. So again, this applies to individuals that are covered by private healthcare insurance, and then that insurer must now cover up to 8 at-home tests per insured individual. So people can go to the pharmacy or the store or go online and purchase a test. No doctor's order is needed, and it will either be paid for upfront or people will submit a claim and get it reimbursed. So the health plans are required to make tests available through preferred pharmacies or retailers and cover those costs. But if somebody goes out of network, then the plans are required to pay up to $12 per test. So everybody just needs to check with their healthcare plans for more details and find out how it's going to work for you. The other issue, as we all know, going through this is the availability of tests because, finding those at-home tests right now is a challenge. So more to come on that, but at least for right now, they're moving towards trying to make this more accessible to individuals. Okay. So vaccine mandates. We all know that both OSHA and CMS issued vaccine mandates, and we've been following their journeys as both have been contested in court. So with OSHA, they withdrew the healthcare emergency temporary standard, and the OSHA vaccination and testing ETS now applies to all employers that have 100 or more employees. On December 20th, they revised the compliance dates. So as of January 10th, yesterday, employers should start collecting COVID-19 vaccination status on all employees. And again, in healthcare, we've been doing this, right? But OSHA applies to many different other industries as well. And then by February 9th, employers should be testing employees who are not fully vaccinated at least once every 7 days. So last Friday, the US Supreme Court heard oral arguments on both the OSHA and CMS vaccine mandates. And some legal experts are predicting that the CMS mandate will likely go into effect, but there was some skepticism regarding the OSHA mandate. But we just don't know what the final judgment will be. They are expecting the Supreme Court to issue final judgments fairly soon, as these are hot topics right now. So we'll just stay on top of this and keep everybody informed. So last week, the CDC issued guidance for healthcare workers and the public related to COVID-19. And so I just wanted to review with you what was said and start with the general public so that you know what was communicated out there. So if a person is COVID positive, regardless of their vaccination status, the guidance is that they should isolate for 5 days. And then if they're asymptomatic or their symptoms are resolving and they've had no fever in the last 24 hours, then the guidance states that they should wear a mask for the following 5 days. If a person is exposed and they're unvaccinated or unboosted, they should quarantine for 5 days, and again, followed by an additional 5 days of wearing a mask. If a person is exposed and they've had the booster shot, then they're just saying that they should wear a mask for 10 days after exposure. So regardless of vaccination status, again, the CDC is recommending that people get a COVID test 5 days after exposure. So again, these are the guidelines for the general public. And then let's take a look at what the CDC issued as far as guidance for healthcare workers. So we all know right now that our healthcare entities are operating at one of 3 levels: conventional, contingency, or crisis level. And this takes into account staffing levels and the ability to provide care to patients. So of course, crisis level is our last resort. But some guidance with regards to this as far as determining what level that they're at, that is up to a facility. So each facility depends Their status depends on their staffing needs, and they make that decision as to what level they are. So first of all, for a healthcare worker who is COVID positive, regardless of the vaccination status at the conventional level, the CDC recommendation is to isolate for 10 days. Or if that person is immunocompromised, they isolate for 20 days. The other option is to isolate 7 days if they have a negative test and have no symptoms or improving symptoms, then they could return to work. If a facility is at contingency level staffing, a COVID positive staff member would isolate for 5 days with or without a negative test. And if they had no symptoms or improving symptoms, then they could return to work. And then in crisis mode, there are no work restrictions. So healthcare is a critical infrastructure, and it needs to continue to be available to meet the emergent needs of the community. So the CDC is recommending that asymptomatic staff be prioritized in this situation before those with symptoms. But again, under these type of circumstances, they would be cleared to work. So this slide looks at return to work guidelines for asymptomatic healthcare workers with exposure. So again, these are not COVID positive, but the staff have been exposed. So at the conventional level, if a healthcare worker has been boosted, there are no work restrictions, and they recommend testing on days 2 and somewhere between day 5 and 7. For a staff member who's vaccinated or unvaccinated, they should quarantine and return to work after 10 days, or they can return to work after 7 days with a negative test. At the contingency level of staffing, if they're boosted, there's still no work restrictions. If vaccinated or unvaccinated, there's no work restrictions, and then they should test on days 1, 2, 3, and somewhere in days 5 to 7. And then at crisis level of staffing, there are no work restrictions for either group. And they are recommending that if vaccinated or unvaccinated, they should test if possible. So these guidelines apply even if it's within 90 days of a prior infection. And currently we know that some facilities are dealing with this. Some are running at contingency levels. We've had a couple that went into crisis, hopefully just temporarily. And so we know that facilities are looking at this guidance that was released, and they're making the best decisions that they can to ensure patient safety and also meet the needs of their staff. It's just a really challenging time, as I don't need to tell you. You know it, you work in it, you're living it every single day. So let's take a look. Here's the community transmission rates of the last week. And again, this is going to come as no surprise to you that we are in the high category for all counties. And so the frequency of testing at nursing facilities is twice a week. So I've included the links at the bottom here if you want to review the CMS requirements and also check community transmission rates. So let's take a look at some of the COVID-19 data. So this slide here is a timeline of daily new cases in the US since January 22nd, 2020. So you can see at the right side of this graph that Omicron has had a significant impact on the daily number of cases. And this data just runs through mid-December, December 18th. And we continue to set records with this surge. On this slide, this data comes from NHSN. It's tracking COVID-19 in nursing home residents in the US. So the light blue line is new resident cases, and the dark blue line is new resident deaths. So this data is through December 19th, 2021, and I feel like so much has actually happened since then even. So we're going to keep an eye on this as new data points are released. And I'm hoping that we continue to see it trending low for our nursing facility residents. But again, so many thanks go out to you, our long-term care providers, and all of our healthcare staff for the extraordinary work that you're doing despite incredibly challenging circumstances. So again, thank you. You are making a difference, and we appreciate what you're doing. Okay, so I'm going to get into some data slides that are specific to Hawaii. This slide shows our total confirmed COVID-19 patients in hospital beds. So again, it goes through January 7th of 2021, and you can see that with Omicron, hospitalizations are on the rise currently. Our ICU bed usage has started to go up again in this current surge. So we're keeping a close eye on that. And then a month ago, when we met, we were talking and we were down here at the lower end. But again, new COVID admissions to hospitals per day statewide has increased dramatically during this surge. So we're on the rise and we're almost to the point, the highest point that we were during the Delta surge. This set of data is actually pulled from the CDC. And so for the week of January 2nd through the 8th, last week, Hawaii had the 23rd lowest infection rate in the nation. So we were pretty much right there in the middle. However, during the entire duration of the pandemic, which again, they define as March 7th, 2020 through January 8th of 2022, Hawaii continues to have the lowest infection rate in the nation. So based on the data that they've been collecting, it looks like the rest of the nation in general is surging at a higher rate than Hawaii right now through Omicron. And then again, taking a look at the week of January 2nd through the 8th of last week, Hawaii had the second lowest death rate in the nation. That's down from the seventh highest the prior week. And then for the entire duration of the pandemic, Hawaii continues to have had the second lowest death rate in the nation, second only to Vermont. And it's not too much of a difference, as you can see. And then this slide shows the rate of confirmed COVID-19 infections and deaths per 100,000 in Hawaii, and it's over the duration of the pandemic. So again, for last week, January 2nd through the 8th, Hawaii's infection rate was 1,298 per 100,000 individuals. That's a new record, and it's up from being 1,010 the prior week. So at the peak of the Delta surge, Hawaii's infection rate was 408. You can see that there. And that was 408 per 100,000 individuals. So last week's infection rate was 3 times higher than the peak of the Delta surge. So again, Omicron has had just such a distinct impact on our community and on our facilities. And we will continue to see where it takes us from here. I'm going to stop sharing now and give it back to you, John. And then does anybody have any questions?
Yeah, that's what I was gonna ask.
Yeah.
Yeah, any questions for Lori or me?
I know that things are changing so quickly with COVID, new guidance and new recommendations coming out all the time. So we'll just continue to keep everyone apprised as best we can of that. But if you do have any questions, you're always welcome to reach out to me. You can email me or touch base call. I'm happy to chat with you further on anything.
Yeah. One comment I just wanted to make is that, in some sense, when we're talking about prioritizing staff and prioritizing who, I think it's important to also take a look at who, what were the conditions, what was the environment like at the time of exposure, and what kind of masks they were wearing, and if you're not already wearing N95s at work, that's something I think you really need to be thinking about doing, because otherwise your risk is that much higher. And then I'd feel a little less comfortable about that contingency or the crisis mode if people are going back, without that N95 pre-exposure even, because that just makes you that much more infectious. So. All right. Any other thoughts, questions?
Hopefully we will come through this, and we're all hoping that it looks like There's been some places that have gone through Omicron, South Africa going up and then had a significant decline pretty quickly. And so we're hopeful that we will follow in that path as well. But
yeah, so hold on tight, right?
exactly.
And we'll be right
Hang
out
in there.
2-3 weeks, I think we'll be okay. So yeah, so the next portion is, if you haven't been with us during the rest of the series, this is sort of a recap of what we've been talking about. And, really just thinking about putting those behavioral activation strategies into place. And I noticed as I was looking at the participant list that Lucas Morgan is here. So thanks so much, Lucas, for joining us. He actually helped me a lot with some of these concepts and these slides. So he is available for questions and clarification too. Thank you, Lucas, for joining us. Okay, so this is our quick review, right? The impact of the COVID-19 pandemic, right, is social isolation because we have social distancing and all that sort of stuff. Reducing the total number of social contacts can lead to loneliness. And loneliness is not necessarily, loneliness is basically a feeling from the lack of meaningful relationships. Some people who don't contact a lot of people don't feel lonely because they're, kind of hermits in the first place, right? But if somebody is a social person, they will particularly feel very, very lonely, right? And it's really a feeling that you get that is experienced from the lack of what they perceive as meaningful relationships. And the experience and the feelings of loneliness that could result from social isolation can lead into depression, which is not a feeling. What it is, it's a clinical diagnosis. Next slide. Right, and then if you have depression, this is which is a clinical diagnosis, it can be treated. And if it's not treated, can lead to weight loss, physical decline, functional decline, that's functional decline, cognitive decline, and earlier death. And it's basically a big cascade of things. And I know you guys have seen this in your facilities, right? From all that social isolation and people eating less, getting more deconditioned, more falls, and also less interaction and just having more cognitive decline as well that you've noticed throughout this whole pandemic. So I just want to keep that goal in mind as we think about why it is so important to treat this. Okay, we also talked a little bit about that PHQ-9, and so this is going to be a very, very interactive session, and it's really a lot of sharing from your parts, because that's what it all comes down to. How do you actually implement this thing? Very nice to say, oh, just fill out the PHQ-9, but actually, what is the best strategy that you've seen doing this? What have you found is the best way to do that PHQ-9 assessment? It's not that simple to do. Yeah, so I'm just going to throw it out there and see if people have ideas. So question, like, do you ask the patients directly? What does that work? What do you do? Who finds it a little awkward to ask these questions? Are there strategies that you find work better than others? And then how do you solicit this information from the other staff? I'm just going to throw it out there and see what people say.
For me, I think the residents that are cognitively there are used to me asking these questions, so it's not really awkward. Sometimes they need it to be explained to them a little bit more, like they don't understand the question fully, but other than that, I get a lot of just no's, period, because I don't think people like talking about their feelings anyway, so.
Mm-hmm. And we knew that, right? People always say, if you're depressed, are you depressed? No. So how do you get around this stuff? What else do you do? Do you find that your staff are looking out for loneliness, depression? Have you noticed more of it lately in the last few months? Or do you find that families are telling you this? Anybody having challenges about working with people with dementia to filling this one out? That's another really common challenge. Who has a good tip? What do you do? Anybody? What happens if you see a person with dementia? What are you noticing? Right, that's what the PHQ-9 OV is, right? Observation, because you're supposed to use your observation skills and see, what are we looking for here? They're looking awfully quiet, right? Or yeah, social withdrawal. Less likely to engage in conversation. And what happens if you do? Go away. Leave me alone. Yeah. Anybody with, I'm sure people have seen this, right? How do you do this? How do you do that PHQ-9 with people who have dementia? Any experiences you want to share? Or what do you tell family members? Okay.
Well, can I add
Yeah.
a couple of things? Sorry. And hi, everyone. I'm a psychologist working mostly with older adults and do a lot of work with dementia within families. And one thing that I like to share with families and also providers and staff is that number one, depression is not a normal part of aging. And I'm sure people know that, but sometimes that creeps into some of our kind of biases, and that within dementias, depression is common and yet not necessarily an inevitable part of the disease process, in the sense that, you know, I've worked with patients where their presentation of their cognition was markedly worse before their depression was treated, because there was a bit of that cognitive slowing that is associated with depression for anybody or many people with depression, even without dementia. So treating the depression with appropriate behavior activation and medication, the mood was up. And then we got a better sense of their cognitive status. So I like to just remind families that it's still worth really trying to treat depression no matter where the person is cognitively, and for quality of life and well-being. So
Thank you. Absolutely. Right. It's part of the ageism thing too. Like, you know, we don't give up on them that easily. I'm sure that there's a little more inside of them that we could spark, right? There's a spark in there. We just have to get it out, right? Okay, good. Next slide. And of course, you know, we talked a little bit about treatment and treating with antidepressants. Hopefully, you know, you've shared the PHQ-9 with the doctor and said, you know, maybe we need to start antidepressants. And I'm sure you guys who have been practicing out there, right, have seen antidepressants being started, and just kind of wondering, your experience with them. Do you see them kicking in? And how soon afterwards do you bump up the dose? Or does it kind of get forgotten? And then the dose doesn't get bumped up for a couple months. I mean, I admit I'm guilty of that too sometimes. And it really just has to be on the forefront, and you always have to keep thinking about that. Antidepressants work very slowly. It takes 4 to 6 weeks to get a good response. And that, if you're not seeing a response, you really should be thinking about switching it or adding antidepressant or changing things up a little bit, and talking to the psychiatrist or your physician to really think about that. That's part of your advocating for these guys, for their quality of life. And yeah, depression isn't normal, and you don't need to lose any more ground. They don't need to lose any more ground than they already have, right? Because every moment counts. So yeah, so that's my thing. Don't give up. Right? Be patient, but don't wait too long. Don't give up. Anybody want to share experience on that? Have you guys seen antidepressants kick in? I have. And it can help you, and we'll talk a little bit about that more later. It can help you, push you into being able to do more of the behavioral activation as well, which is the actual treatment that works. Okay, so then we also talked a little bit about, before behavioral activation, just basic non-pharmacologic approaches, right? Trying that gentle and respectful approach, intentionally making a connection, intentionally having interactive activities, not isolated activities like reading a book, right? Or watching TV, just something more interactive. And validation, which is not arguing with them, acknowledging their feelings and things like that. And I just wanted to open that up for you as well, and see if people have tried these with people who are depressed, and did it help open things up? It may seem like, well, no, duh, this is intuitive, right? But sometimes we forget. And sometimes we need to remind ourselves, I do, right? To be very intentional about this.
And I'd just like to add that compassion fatigue is a real thing for folks working in helping professions. And so all these things which are so critical to being able to help in the most helpful way is your presence, and that takes energy from you. And so if one thing is sort of provider self-awareness of like, wow, I'm really not being very patient, that means maybe I need something to address some of this maybe burnout and stuff, which makes it harder to be patient and gentle and respectful and do validation and stuff like that. So sometimes that makes it harder to do these things, and so important to do.
Yeah. And sometimes families also forget this too, right? Unfortunately, right? We're all guilty. We take our own families for granted, right? And you know what? Yeah, maybe we could just use a gentle and respectful approach and take time to make a special connection, and take time to just acknowledge feelings. And you don't need to, give any advice or tell them what to do, right? And maybe it is time to do something together, not just divide and conquer and everybody does their own thing. So yeah, this works for us as well. So thanks for the reminder, Lucas. Okay, so let's not forget these non-pharmacologic strategies. And this is just everyday stuff. This isn't even a program. It's not, it's just everyday stuff, right? Just to open these guys up. Okay, and then we talked a little bit about behavioral activation, as this is really the key to depression treatment. And it's even more important than antidepressants, you know, and, you know, as a doctor, you think, oh yeah, this is my thing. I write prescriptions and stuff, but you know what? It's not even all that important. The most important thing is this, is the behavioral activation. And what is behavioral activation? It's an outside in approach, right? It's all about the behavior. You have to identify person-centered and pleasurable events, just put it on the calendar, you know, make great efforts to remove any barriers for these things to happen, and then watch their mood, and the mood should follow, right? So yeah, we've seen Eeyore through this whole 4 months or so, right? And he's the quintessential depressed guy, and you know, you got to find him things he really likes to do. He loves thistles. You got to take him to the thistle garden, and you got to pick flowers with him, and you know, maybe sit around and listen to the birds or something, and find something that he actually likes, not something that he doesn't like, right? Yeah, don't send him into go play bingo. He's not gonna like that, right? And then if you identify these things, the mood should follow. So yeah, it's kind of counterintuitive. So instead of, you know, finding uh, oh, they don't feel like it, then well, I tried, and then you walk away, right? No, we're actually going to do the behavior, and then the mood should follow, because it's a positive reinforcement approach. Next slide. All right, and we talked about grapes. I think Lucas brought this one up, and a lot of people I spoke to really likes this grapes analogy, right? And this is, yeah, being gentle to yourself, being gentle for the resident. Relaxation. So what, making time to relax, like namaste, massage, watch the fish, do something that's relaxing. Do something that can accomplish one thing. You don't have to accomplish a lot of things, just one thing, right? Fold laundry, write a letter, do something like that. Pleasure, doing something that's pleasurable, whether it's tasting a sweet fruit or a sweet chocolate. I like chocolate, so yeah. Petting an animal, listening to good music, something that's pleasurable. Exercise, even if you're not walking, stretching feels good too. Maybe try stretching, or just moving a little bit. Sitting in one place doesn't always feel good. Try moving around. And yes, thank you, Lucas. There's an S at the end of grapes, and that's social connection. Thank you. So this is a great acronym, and I think we should all be doing this for ourselves as well as for others. And you don't have to have a lot of time for it. You just have to be very intentional about it. Next slide. Yeah, and then try to make a plan for every day. You don't have to fill every day with all the grapes. I think that's too much to ask, and I'd get burnt out thinking about it. But maybe, you know, if there's like one thing you can do each day, one thing that you can look forward to, a personalized calendar with these grapes, and include a mix of different kinds of activities, different parts of the grapes. Right. So, you know, and figuring out the right part of the day to do it and things like that. So just a little vary. So it's not the same every single day. And then of course, they're going to say no, right? Because Grumpy Cat says no, and they don't want to. So, you know, what do you do when they refuse to do any activities? I'm sure you've had those guys. And so I'm going to ask you guys for advice. What do you do? When you have residents, you invite them to something and they say, no, leave me alone. I like to stay in my room, in my bed with the sheets over my head. What do you do? Oh, look, Dana says putting activities on my own calendar helps me too. It's true. If you're like a checklist person and you want to check things off your list, sometimes I got to put things like that on my checklist, even if it's a small, tiny thing. Okay, any advice for when we encounter residents who don't want to do stuff?
Well, and I don't, feel free, anyone jump in if you have, experience and things that you've done in the nursing home, and because I don't work there. I do see folks in different settings, but one thing is that this can be very frustrating for providers, because we know that this is good for folks, and yes, theoretically, and we have confidence that if behavior activation occurs with some consistency, mood should get better. And yet, by definition, most folks who are depressed are not going to want to, because low motivation and lack of interest, anhedonia, are key features of clinical depression. So expect this and know that this is part and parcel of why a person stays stuck in many cases, because their get up and go has got them and left. And so validation here, of course you don't feel like doing this. Of course this feels stupid or useless, or why would smelling flowers help you right now? Of course this is how it feels, because that's what depression is like for so many people. And it sounds like for you. And so often I try to, if I have a relationship with the person, I ask them to trust me, and that I really do believe that this is something that with time and with some amount of effort will help them feel and see things differently. One key thing I think is to dial down the scale of the goal to the smallest possible thing that the person is willing to do, if for nothing else, for you, so if they're not going to walk for 20 minutes, walk for 2 minutes, stand up and walk around your room, 2 times, or so, to just get them going, doing it with them, if that's feasible for the setting. Doing something with them is often has a higher likelihood of having more engagement. So those are just some some ideas to try.
Thank you. Okay, next slide. And this is just another reminder slide that sometimes it takes a team to get over the bigger hurdles. Some people are more challenging than others. So medicine can help the behavioral activation start to happen. I always say medicine is to push people out of the rut. You got to push them out, because otherwise they're stuck down there. And then sometimes the psychologist can help support that as well, encourage and support that if they're amenable to that, right? And if they're cognitively intact and they're able to do that cognitive behavioral therapy. A lot of folks cannot, but some can. And if those who can, take advantage of that. And then once you can get all these supports in there, hopefully we can get that behavioral activation going, implementing that, because that is actually the medicine that will overcome the depression and get them into the zone of not depressed. And so I always like to visualize depression like this. You just got to push them out, push them out, pull them out, and then get them going. And slowly things will turn around on their own. You got to trust that that's going to happen. Next slide. Oh yeah, and then also just a reminder that repeating that PH29 serves as feedback, and the whole goal is for the team to modify the care plan. Next slide. So this is just the repeat SBAR thing. This was Eeyore's SBAR. This was actually from last time, except things changed a little bit. His PHQ2 went 12. PHQ-9 went from a 12 to a 10. You know, he's been on Zoloft daily for 4 weeks, right? His PHQ-9 is only slightly better than it was 4 weeks ago when it was 12. And then these are all the descriptions of all the things down here. And the R is, I'm worried that he is still quite depressed. We are still having trouble engaging him in his favorite activities. Do you want to adjust to Zoloft, consider another antidepressant, and maybe have the psychiatrist see him again? You know, things like that. So I'm going to encourage you to do that PHQ-9, follow up, keep advocating, and keep pushing, and don't give up. And you can use the SBAR format to push that through. Next slide. Okay, and of course, don't forget to revisit and revise your care plan. It's not the same. It shouldn't be the same all the time. And in fact, there's the beautiful thing about behavioral activation is there's lots of ideas out there, and you can keep trying new ones. Next slide. Okay, so I'm going to let Dana talk quickly about the regs.
All right, so did my slides get entered, or do I need to share my screen?
Oh, you know what? I think, oh, sorry. I think I got the wrong ones in here. So you
Okay.
should share your screen.
No worries. All right, are you seeing the presentation?
Yeah, well, we're seeing the whole.
Yeah, I'll start
there
it.
we go.
Just make sure I'm on the right spot. So I just wanted to, there we go. Review some of the things that I reviewed, over the course of this, talking about depression management. And I know I just have a few minutes. I do want to acknowledge, when you were talking about behavioral activation, Dr. Wen, that a lot of times with that, the calendar of activities will fall to the CNAs or maybe activity staff. And I know, I just want to acknowledge that I know that people are really strapped for staffing right now. And so it can feel overwhelming. May require some creativity when you've got a resident who maybe could benefit from this, to make sure that it's not the thing that gets pushed to the side. Because I think when a resident says, I don't feel like it, sometimes the path of least resistance may be to say, okay, and just let it slide, because I know our staff are so busy. So first, I just wanted to review possible warning signs again. Dr. Wen has covered most of this, I believe. There were some in here that I think bear maybe some repeat, and that's especially like in your dementia folks. I would think that if you're seeing a real increase in their irritability or aggressiveness, that might be a sign. It's obviously could be a physical sign as well that something's going wrong, but it could also be depression. The monitoring sleeping is important. I think those are two that stood out to me really in this list that was on the National Institute for Mental Health that might apply to our residents. And having said that, we did touch at one point on the Interact Stop and Watch tool. You used to be able to find this on the Interact website. It looks like now they're contracted maybe with MedPass and that they're selling them, but I'll dig around and see if I can't find them for download, or you can just screenshot it like I did. I don't know how many folks are using this. I know it takes a bit to get into the habit of it, but I think these are critical to have, say, on the nurses' med carts, where anybody who's interacting with a resident can utilize it if they see something that just is off and they may not know what it is. It could help identify any number of things, but one of those would be depression. So some of the changes that you might notice of somebody that's just not behaving the way you're used to. I encourage even, our EVS folks to feel empowered to use these, because they're often interacting with residents in a way that's different than anybody else and may notice when something seems a bit off. Also available in the Interact, and this looks teeny tiny, but you can find it. It'll be in this, I'll send a link actually where you can find this and not end up having to pay for it. But it's a care path for a change in behavior that kind of walks you through steps that you can take if you're seeing worsening behavioral symptoms. And, noting what the symptoms are, what their vital signs are, full assessments, things you might need to notify your provider for, and tips for how you could manage behavior changes in the facility. And it applies not just to things that might be depression, but any other behavioral symptoms as well. Early on, we talked about the QMs. We went over the QM for depression. That feeds into your 5-star and your quality measures. This is the long stay tip sheet. These are available on the Mountain Pacific website. So mpqhf.org. And I have the link here on the next slide. I'm not going to go through this, but it shows you what feeds your QM score. And then the bottom half of that sheet talks in that blue box, I think is really the most handy section of these tip sheets is if you're triggering on a depression, on your quality measure for depression, here are some ways you can consider addressing the residents who are triggering. Some questions to think about, some questions to bring up in your IDT. Are other causes for being addressed? Are they hungry, thirsty, bored? Do they have adjustment disorders? What else might you want to think about for those folks who are triggering on the QMs? One QM we didn't touch on earlier was the weight loss. And again, this could indicate any number of things, but it could indicate some mental status changes as well. And I'm not going to go into how it's calculated, but it's here and it's available on the tip sheets. And again, it's got a nice substantial list of things you can consider if you've got somebody triggering for weight loss. And I know that's, on everybody's radar pretty much all the time. And things that, just to make sure you're capturing accurate weights, but then also what else can you do to address weight loss? And all those things might be something that you might use a stop and watch for. I think the weight loss would be probably trigger to your nurses or your DONs or your dietitians. But if somebody's maybe not eating enough, that would be a trigger, or not eating what you're used to seeing them eat. That could be a trigger to notify somebody. So I guess my takeaway is to make sure that all of our staff feel empowered and welcomed when they bring up concerns about residents. It could be depression, it could be anything. I think depression sometimes isn't considered as readily as other causes. And I think, of course, often that's completely accurate, but I don't want us to forget about it. I constantly remind myself that, if I was in a resident's shoes, how challenging that would be, and to have that kind of empathy and bear in mind that we're taking care of a whole person.
Thank you so much for reminding us about all those tips and all the tools that we can access. And of course, we can always email Dana anytime we want to get any more of these tips or suggestions.
Yeah, anytime.
Yeah. So I know we're sort of at the top of the hour, and time just flies so fast when we're having fun. But so anyway, I just wanted to point out that there is a link in the chat box for you to get CMEs for your continuing education credits and the social work credits if you want to. So make sure you click on that and fill out the evaluation form right away, immediately following the session. And I don't know, I had a last slide, but it's okay. It was just basically saying Happy New Year and just thank you everybody for everything you're doing and the ways that you're advocating for our residents. And, here's wishing for a better new year and for the residents, but also for yourselves. And, I think we're all tired, but even more importantly, we need to learn how to take care of ourselves. And hopefully some of these ideas will help us take care of each other and take care of ourselves, and then take care of each other as well. Because you know, we have each other. So thank you. Any other comments or thoughts? I'm willing to stay on for a little while, and you know, we can just talk story, talk about cases, anything. Oh, everybody's so shy. But I appreciate everybody.